Hello, I'm Michelle Levander, Director of the USC Center for Health Journalism. Thanks for joining us today and welcome to our Health Matters webinar, covering coronavirus, Biden's first 100 days. 2 weeks have passed since President Biden's inauguration, when he unveiled an ambitious plan to stem the pandemic. On his first full day as president, he signed 10 executive orders and released a 200-page plan to reboot the federal COVID-19 response. But with new and more dangerous variants of the virus emerging amidst a chaotic vaccine rollout, will his ambitious plan for his first 100 days be enough to slow coronavirus deaths, get Americans back to work, and kids back in school? And how much can be accomplished with a divided Congress and a deeply mistrustful public when it comes to everything from mask wearing to the safety of the vaccines? Here to help us explore the policy agenda and ideas for reporting on these central issues for your audiences and communities, we're joined today by two distinguished experts. Amy Goldstein, who reports on national healthcare policy at the Washington Post, is one of the newspaper's main reporters covering the coronavirus pandemic. During her 3 decades at the Post, she has written about Medicare, Medicaid, Social Security, welfare, housing, and the fragility of the social safety net. Amy was part of a team of Washington Post reporters awarded the 2002 Pulitzer Prize for national reporting on 9/11. She was a 2009 Pulitzer Prize finalist for stories she co-authored on the medical treatment of immigrants detained by the federal government. She's been a Nieman Fellow at Harvard University and is the author of Janesville, An American Story, a close-up look at a small Midwestern city that lost many jobs during the Great Recession. We're also joined by Dr. Lena Wen, an emergency physician and public health professor at George Washington University and an expert in pandemic preparedness and response. She's a contributing columnist for the Washington Post and an on-air commentator for CNN as a medical analyst. She's been a frequent guest expert on the COVID-19 crisis for CNN, MSNBC, the BBC, and NPR. Previously, she served as Baltimore's health commissioner. She's also been the director of patient-centered care research in the Department of Emergency Medicine at George Washington University, president of Planned Parenthood, and a consultant with the World Health Organization and China Medical Board. Dr. Wen earned her medical degree from Washington University School of Medicine and her master's degree at the University of Oxford, where she was a Rhodes Scholar. So she's also the author of the book, When Doctors Don't Listen. In 2019, Dr. Wen was named one of Times Magazine's 100 most influential people. We want to thank the Commonwealth Fund, the National Institute for Healthcare Management Foundation, and the California Endowment for supporting this program. We also want to express our appreciation for donations to support this programming from individual participants like you. You can tweet about this webinar at the hashtag #CoveringCoronavirus. A word about our format today. We'll be hearing from our panelists first, and then we'll turn it over to our audience for questions after a little bit of back and forth between the two of them. Because we have many people participating in this webinar, we'll ask you to write your questions into the Q&A panel of Zoom. You can write us there if you're experiencing technical problems as well. We'll be archiving this webinar at centerforhealthjournalism.org. And now let's get started. Amy, tell us a little bit about the landscape during Biden's first 100 days.
Sure, Michelle, thank you for that nice introduction. And I must say, it's really nice to be spending an hour talking about the work that I do these days rather than doing it for an hour. So I thought that I would start by talking about basically 3 things. First, a quick typology of what's what with covering the pandemic, no matter who the president is. Secondly, what the new Biden administration says it's doing about the pandemic. And thirdly, where to find good stories, whether you're a national reporter or writing for a more local publication. So to start with a typology, I'm going to breeze through this stuff pretty fast. And my main message is that the pandemic is still the pandemic, no matter who is in the White House, which means that with this transition from the Trump administration to the Biden administration, there's still the same problems, the same opportunities to fix things, and the same opportunities for new problems to be arising. What's just changed for journalism is the emergence of a kind of compare and contrast situation in which we can look at how one administration is approaching the federal role with this massive public health crisis compared with how the former guys did it. So that's the big change. So the problems. There is too much virus spreading. We've known that for a long time. On top of that now, there are new variants which spread more readily, and some people think may be more so-called virulent, may cause more health problems. That's one problem, no matter who's in the White House. The problem for government policy is vaccination. I mean, it's very good news that in under a year, 2 new vaccines have been authorized for emergency use. But how well are they getting out? That's a government policy issue. Testing, there's all along been kind of a chronic problem with not enough tests being accessible enough sometimes. Protective gear, there have been shortages still of N95 masks and gowns and gloves, and these pop up. They were absolutely prevalent at the beginning of the pandemic, but even a year in, these are still problems sometimes in some places. There's also a big policy problem for any administration in persuading the public to take those public health measures that people know works. So you hear the Biden administration, more than the Trump administration, encouraging mask wearing and keeping safe distances and things like that. And then running through all of this is my final typology point. There's the question of equities and disparities and who's getting sick, who's dying, and who's getting help. So that's a very quick tour of what's what with the pandemic. In terms of what this new Biden administration is doing, I think in the very broadest strokes, you can understand the new president to be saying that he and the people around him are saying they want a stronger federal hand. The Trump administration was very eager to defer to states to do things like set up testing plans. The federal government allocated vaccine in the last couple of months to states, but it's really been up to states to determine where the vaccine goes from there. And the Biden administration has been very big on saying they want the federal government to have a stronger role. So far, they've been providing help to states. They haven't really been taking over state functions. So that's a distinction that journalists, no matter where you are, can be listening out for when you're thinking about what stories might be pertinent in your own communities. The other thing that the Biden administration has been saying much more than the Trump folks is that they are really believers in adhering to what the scientific evidence shows. Also, in terms of equity, cemented their what they say about their commitment to really wanting to be equitable in their approaches to things by creating a new equity office led by a woman who was part of the transition team in the couple of months between when Biden won the election and when he was inaugurated. So that's a way of thinking about their overarching values and how they differ from the Trump administration. In terms of what the new administration is saying and doing, I think you can think of it in 2 basic categories. One is what a president can do on his own without permission from anybody outside the administration. And as you said, Michelle, President Biden has been very quick to take a whole set of actions to look like he's really on the case. So on day 1, for instance, he did 3 things. He said that he was going to require masks to be worn where he could. President can't on his own say everybody needs to wear a mask everywhere in the country, but he can say that masks can be worn on federal property by federal workers and contractors and things like that. So he did what he could with respect to masks on his own authority. He also on day 1 announced that he was going to stop a process that his predecessor had undertaken to begin withdrawing from the World Health Organization. Biden has stopped that, and that very week, his first week in office, Anthony Fauci was a representative of the United States to a big meeting of the WHO. So that was kind of a concrete action that symbolized his new stance towards international collaboration and pandemic fighting. He also, this is kind of an inside baseball thing, but he also recreated a White House office that the Trump administration had killed off that's dealing with biodefense, which is meaning pandemic threats and other kinds of medical dangers. Those were all day 1 things. Now, there are other things. I mean, I could give you a set of second day actions, but they also fit within the category of what a president can do on his own authority. Now, the other group of things is stuff that Biden has made very, very clear he wants to be done that would require money and permission from Congress. And he didn't wait until he began president to start to say very explicitly what he wanted those things to be. So the week before he was sworn in, he unveiled a plan that's a $1.9 trillion plan that he's asking Congress to fund and to approve. That would both help with the pandemic, but also help with some of the broader damage to the nation's economy that's been caused in the past year by the pandemic. So how that's going to play out, we're all just going to have to watch and cover. Part of that money would do a couple of very specific pandemic things. And these really are exceptions to what I said a moment ago about the Biden administration so far saying it's giving more help to states without taking on more federal responsibilities. In two ways, he's actually doing federal stuff here. One is that he wants to hire 100,000 healthcare workers to go into communities and help to provide vaccination and also help persuade people that getting vaccinated is the right thing to do. And those would be federal workers. That can't happen unless Congress passes this big bill the president's asking for, or some part of that bill. Similarly, the president has said that he wants to he set a goal of 100 new vaccination sites during his first month in office. So that also is the federal government doing something as opposed to just helping states do what they've been wanting to do all along. So that's just a quick tour of what this new administration is saying it's doing. And I think part of our role is going to be kind of a form of accountability journalism, watching over time to see what of those things the new administration says it wants to do is actually happening and how well it's going. I think of our role as journalists as being something other than high-priced stenographers. I mean, I remember years ago when I was covering the George W. Bush White House for one of his terms, I would spend some days going on day trips with the president where he would give a speech somewhere and then get back on Air Force One and go home and sleep in his own White House bed. And I always felt it was really important not to just be a glorified stenographer, that I wanted to, even writing a daily story on deadline, find something in which I was bringing context or perspective to what the president's speech was, which is often the same speech he'd given in other cities days and weeks before. So I think there's something very analogous to that way of thinking as we're covering this pandemic. Even in a daily story, looking out for if the White House is announcing something, and I should say the White House has been, in its 2 weeks running things, really big on announcing things. They're having 3 briefings a week, and yesterday they added another one to announce what was actually a pretty small increase in the allocations of vaccine doses to states and the beginning of a program giving vaccine doses directly to retail pharmacy. But my point is that as these things are being announced, I think it's incumbent on us as journalists to really shed light on what is new, what is not new. The Biden administration likes to say, well, this was our idea, but we should really take a look at, were there seeds of it in the previous administration or not? I think we can take a look at how much this matters now, how it compares to other options of what could be being done by the government, who likes this and who doesn't like it, how likely this is to come to fruition. So those are all kind of accountability questions that we can weave into stories on deadline, but they're also things that we can come back to and write about as time goes on and we see how these things unfold. So let me just mention a few things that I think can be really good local stories as well as national stories. One has to do with vaccination. Some of you may have heard Tony Fauci or other people saying that vaccines are really the biggest tool that the country now has to try to tamp down the spread of this pandemic. And looking at how that vaccination is playing out in given communities, I think is a really central role that any of us can play to try to track what's happening where our readers live or listeners live. I think that, and there are big equity questions about that. What happens when some people get vaccinated and others don't? One of my colleagues just wrote a story about that. That was on the front page of my newspaper this week. And the question is, even within families, if one member is eligible for a vaccine and other family members haven't gotten vaccinated, how do you handle that? Because it's not fully understood whether people who are vaccinated can still transmit the virus even if they get infected, even if the vaccine is protecting them from getting sick. That seems like a big question that's going to play out in every single community in this country. I think that there are questions around what the government is doing with respect to the variants that also can be looked at a local level. There are 3 variants that are causing worry, one that originated in Britain, one that originated in Brazil, and one that originated in South Africa. How prevalent are they in any given state or any given community? And importantly, it's well established that the United States has really lagged in terms of something called genomic testing, which is basically once you have a positive test result, figuring out what variant of the virus it is. There's going to need to be a lot more genomic testing, the Biden administration says, but is that happening in a way that's going to prevent these variants from becoming kind of a big phase 2 of a pandemic that started a year ago with more worrisome kinds of strains? And finally, I think that there are ripple effects of the virus that we can be watching out for in communities all over the place, and how well the Biden administration is addressing those. I wrote a story last spring, so it was pretty early on, about one community in West Virginia. I actually did this reporting from the safety of my telephone in my home study, but I tried to make it read like I was in West Virginia, partly looking at Google Maps to have people describe for me what was up and down Main Street. But the point was that there were people who were losing jobs, and by losing jobs, they were losing health insurance. And what strains was that putting on this community health center that had been strapped to start with? That question about people who are losing insurance is something that's prevalent all over the country. Now, the Biden administration just last week announced that for 3 months, starting the middle of this month, it's going to be reopening the Affordable Care Act health marketplaces for people who qualify for ACA health plans. We can be looking all over the place at how many people are actually enrolling, whether that's a good talking point that the president announced, or whether it's really making a difference in terms of stemming some of the underinsured problem that's growing because of the pandemic. And finally, similarly, I think it's worth taking a good hard look at Medicaid. Because Medicaid rolls are growing in many parts of the country, and that's coinciding with states being absolutely devastated in terms of their revenues because of the economic declines that this pandemic had caused. So looking at what's happening with Medicaid and who's getting on and what burden that's imposing to states, and whether states are having to cut their programs because of the new burdens of enrollment, is something worth paying attention to. I just rattled off an awful lot of things. I'm going to stop now, and I'm happy to answer questions later on.
Thank you so much, Amy. Really very helpful. And we're going to turn now to Lena. Tell us, as a longtime public health practitioner, where do you think we need to go from here?
Well, thank you for that kind introduction, Michelle, and it's really a pleasure to join you all in the important work. And I have to say, it's also a great honor to be on the same panel as Amy, whose work I read all the time and is incredibly prolific and has covered every aspect of coronavirus. So glad to be learning from all of you today. So I want to also talk about 3 areas in this presentation. I want to talk about the lessons learned thus far in the pandemic response. I think this is what we think about every day for those of us who are in this public health and health policy world. But I want to summarize 5 lessons. Then I want to give my analysis of the Biden policies thus far that Amy has outlined so well. And I also want to give 5 takeaways from it, I think in terms of 3s and 5s. So 5 things from Biden's policies. And then I also want to give you my take on some things that I hope will be covered more maybe some story ideas, but other things that I just, as a person consuming the news, as a person who's participating in it, would like to see more of. All right, so key lessons learned, 5 things. First, I think we've seen why we need a national coordinated response. We've seen this throughout the pandemic, that when we don't have a national strategy around PPE and testing, we have situations of states bidding against one another, and locales and hospitals for masks. We've seen piecemeal approaches to testing with no general strategy, which, by the way, we still don't have. We still don't really have a strategy around testing, as in, should we be doing regular testing at home? Should we be doing testing with PCR testing in some circumstances, antigen testing in some circumstances? Having such a national response is important. And I think we've really seen what happens when we don't have such a response with vaccinations, when the previous administration seemed to have ceded its responsibilities after Operation Warp Speed. They saw it as basically ending at the point that vaccines are developed and shipped to the states, but not having an oversight and guidance responsibility after that. Second lesson is, without data, we are flying blind. We look at a year ago, we thought that we were fine, when actually we were not, because every case that was discovered then was a canary in a coal mine. And we're now seeing a repeat of that now with these variants, as Amy talked about. We're just not doing the genomic surveillance, and therefore we actually don't know how prevalent these variants are actually here. Third lesson is that hospitals are the last line of defense, not the first. I'm an ER doc, and I can tell you that it's been very hard for me and my colleagues to be in the hospital, treating patients, seeing people dying and saying goodbye to their loved ones over FaceTime, and then leaving and seeing people indoors in restaurants without masks, drinking together. We in the hospital can do our best to treat patients, but if people are not doing their part, we see the catastrophic outcomes that we have. Fourth lesson is that public health depends on public trust. And when that's eroded, it's very hard to get it back. We've again seen what happens in this response when there is mixed messaging between our public health officials and our elected officials. We've seen what happens when there is politicizing of basic measures like mask wearing. And a lot of it, again, with the previous administration, is that when there were changes in guidance, which, by the way, should happen, right? As you get more science with a new virus, you should have a change in guidance. But when that's not explained, it looks to people as if scientists don't know what they're doing. And that, in fact, is what happened with the changing guidance around masks. We initially said no masks, in part because we didn't have supplies for healthcare workers, but also because we didn't know about aerosol transmission. We didn't know about asymptomatic transmission. When the science changed, the guidance also changed. But because there wasn't the opportunity to really explain it, it looked like scientists didn't know what they were doing. And so having that clear, constant communication from experts is really critical. Fifth lesson that we've learned is, I think, to the point that Amy very well described too, is that COVID-19 did not create many of these problems that we're seeing. COVID-19 did not create disparities, but it did unmask them. COVID-19 did not create the underinvestment in our public health infrastructure, but it has exposed these longstanding problems of underinvestment, under-resourcing, understaffing of local and state public health. And I think that in moving forward, there is an opportunity to then say, well, now that we have exposed these problems, how do we make sure that these disparities are not exacerbated and that there is renewed focus on these issues? So let me move on to the second section, which is how my analysis of President Biden's strategy to address all of these elements. Amy outlined, I think, beautifully what has been done thus far. I would just say that on my end, it was quite incredible that within 24 hours, less than 24 hours of being in office, President Biden and his team outlined a national strategy, which is what we've been missing all along. It was also has been very clear that the Biden administration intends to assert the role of the federal government, which is to guide this process, is to not be the one doing everything. It's of course in partnership with local and state public health, but that there is a very specific support, guidance, resource oversight process. So 5 things that I actually hope will be done more, and things that we should be paying attention to. One is I think the federal government should take an even more forceful role. And specifically, here's one thing, and I wrote a column actually about this, about how I actually think there was one part in the Trump plan around vaccines that's really good, that the Biden team is very explicitly not doing, which is to allocate doses to states based on efficiency of distribution. We have a big issue, as you all know, where some states have been very efficient and some states have not. I don't want to perpetuate inequities. I think what we should do is to look at the states that have not been doing as good of a job to say, what is it that you need? Do you need more resources? Do you need the federal government to stand up vaccination sites? What's happening here? But in the meantime, don't let millions of doses sit on shelves in refrigerators. Reward those states that are able to get out doses quickly. I actually wrote another column where one of my ideas is to select 10 cities to pilot mass vaccination programs, as in there are cities that have very robust public health infrastructure, Chicago, LA, New York City, among others. They are capable of delivering many more doses than they currently are. Give them those doses, see how they do it. Let them write the playbook for how mass vaccination can be done. And I think that's something that, in the name of equity, the Biden team is not interested in. But I think that that's something they should actually take another look at. The second issue here is around accountability. Yesterday, the Biden team announced that they're going to be distributing vaccines through 6,500 pharmacies as a start, which I think is great. And local pharmacies are where many people already trust to go for their care. These pharmacies also know how to do vaccinations. I think this is really important. But here's my question too. Where is the ultimate accountability? If there are pharmacies that are underperforming, who is even keeping track of this? If one pharmacy is so efficient that they distribute all their vaccines within 2 days, but another pharmacy is hanging on to them for 2 weeks, shouldn't there be a reallocation that is occurring? Or if a pharmacy is more efficient than a local health department, or a hospital is more efficient than that pharmacy, then why not give the doses to those who are able to perform the best? By the way, you can also resolve this equity issue too through tracking, because you can also have very explicit metrics. For example, you could say in these metrics that a certain percentage of those doses have to go to the community that's around the pharmacy, or something like that, so that you're not perpetuating inequity and in fact are intentionally focusing on it. But having that ultimate accountability is really important. My third point in the analysis is, I've been watching, and I'm sure Amy and many of you have, all these briefings that are being done, which I think is terrific. I think it's wonderful that we're hearing regularly from our scientists. I love that equity is a part of the conversation. But one issue that I've noticed is that the Biden administration has continually to skirt around what I think is the elephant in the room, which is, should there be an explicit racial preference when it comes to allocation of vaccines? Many public health experts have argued yes, many have not. And it would be really helpful, given that equity is part of every conversation, and the Biden team has very explicitly talked about equity as a guiding force. What exactly do they mean? Yes, targeting mass vaccination sites. Yes, using social vulnerability index. But what about this issue of racial preference? The fourth thing, I hope that the Biden team does even more. I wrote another column. I wrote a series of columns actually about this when it comes to talking about an area that is the primary area in many parts of the country of driving spread, which is indoor gatherings of family and friends. We know that from October onward, we had growing data that it wasn't so much these formal settings. It wasn't a concert or a school or a restaurant even that's driving spread. It's people who are having dinner with their extended family and friends, having game nights, Super Bowl parties, etc. What I really hate is to see schools being closed only for play dates and birthday parties to be happening. I hate to see restaurants being closed and hurting livelihoods only to have people gather in their homes having dinner. I understand that regulating indoor gatherings is very difficult, but there are states that have put bans on indoor gatherings. And I hope that that's something that the Biden administration ends up talking a lot more about, because again, we could end up hurting our schools and our economy when it's actually people's individual behavior that we should be looking into. The fifth, and perhaps the biggest area that, again, I think the Biden administration should go much further on, I've written, again, pretty extensively about this too, is around the need for them to be much bolder with their vaccine goals. At this point, Amy described very well this race against variants that we have here. And we have what we really need is a man on the moon moment. We need to be bold and aspirational. We're asking the American people to do really hard things. The Biden administration is asking Congress to do really hard things. They need to be asking themselves to do this very hard thing as well. President Biden called the Trump plan a dismal failure. But that Trump plan was basically administering 1 million vaccinations a day, which is the equivalent of 100 million in 100 days. And so if that's a dismal failure, then what should the actual goal be? I think that goal should be set much higher. Even if the Biden team is unable to meet that goal, they should still set that man on the moon goal, and then they can track their progress along the way. All right, now I want to talk about the 5 things that I wish were covered more, that I hope all of you will be covering more. First is, I hope you'll write more about the good stories of vaccinations. I hope you'll be, there'll be many more community vaccination stories that are going to be coming out. Community vaccination drives in schools, pop-up clinics in churches, ways of delivering vaccines even door to door, as is happening in some places like here in Baltimore, in senior buildings and maybe in senior centers. I think these stories will be really inspiring. And I think will also be, you all are the ones as local regional reporters, you're going to be seeing these stories firsthand. And I think by telling these stories, you'll be able to help share best practices and also inspire others to do this work too. The second thing is, I hope more is going to be written about accountability. I would really love to see, and this is not happening anytime soon, but I would love to see a dashboard, not just of where vaccines are going and who's getting vaccines. I think that's really important, but specifically, where are vaccines going? Where's the bottleneck? As in, are vaccines getting distributed to states, but then states are giving it to hospitals and it's getting hung up in a particular hospital? Is that the problem? Is it that a particular pharmacy it's getting hung up in? Having that kind of accountability is really important. And short of that dashboard, all of you as the people on the ground can be tracking what is actually preventing the speed of distribution that we know that we need at this point. Third is real scientific disagreements among experts. By the way, this is not meant to be a bad thing to say that scientists don't know what we're doing, but that there are actually a lot of gray zones and reasonable people can have differing opinions about it. A relevant issue right now is this issue of, should you give everybody, as many people, first doses as possible and hold back on that second dose? Or should you try to give everybody that guaranteed second dose? Instead, I have a very specific point of view here. I think that the guaranteed second dose is very important because that's what the science shows. But I also think that there is a reasonable point of view of we're in the middle of a pandemic and we have to give as many people some level of protection is better than no level of protection for half the people. So in any case, I think that highlighting those disagreements and talking about how there is this big gray zone of uncertainty is actually okay. Fourth is this issue of speed versus equity. I had focused on this in some of my writing and a lot of my work. I hope we'll get to talk about the disparities in a bit too, but I'll just highlight that there was a very interesting set of council meetings in Washington, D.C. that really talked about and fleshed out this issue of speed versus equity in distribution. And I think anyone who says that this is not a real trade-off is not being honest, because there is that trade-off. The question though is, how do you become intentional and accomplish both at the same time? And then the fifth thing and last thing is, where are people getting ill? Again, growing data are illustrating that it's in informal settings, but I can tell you anecdotally from the patients that I see, many people have no idea where they're getting sick. And I think especially when we get more contagious variants that are around too, we will have a lot of situations where people don't know how they're getting sick. And I think all of your help in figuring out, in highlighting this, that people don't know how they're getting ill, the activities that we thought were relatively safe are no longer because of these variants, And I think similarly, on the other side of this, good stories of how people are keeping safe, restaurants that are doing the right thing, schools that have the proper protocols in place, I think will also be really important as we go through the next phase of this pandemic. Ultimately, this is going to take all of us. And I just wanted to thank you all for the terrific work that you're doing every day.
Thank you so much, Lena. This is really a fabulous overview, and you've packed so much in. I'm going to ask both of you now to answer a few questions, and feel free to kind of pipe up if I ask one of you a question and the other one of you has something to say. And then after we're done with that, we'll turn to questions from our audience. And just a reminder that there's a Q&A place in your dashboard where you can enter questions for our two panelists. So please do go ahead and do that. I'm seeing a few come in, but we'll have time for more. So just let me first start out with a really big question for both of you, which is, what do you see as the most important aspects of covering or reporting on the pandemic and the Biden administration's response in the coming months?
Well, there's no aspect that we've just talked about. And I should say, Lena, it's a real pleasure to be sharing this panel with you as well. We've spoken on the phone many times, but I don't think we've actually ever seen each other. We're sort of close to that now, though not quite real. I mean, there's no aspect of what the two of us just talked about that doesn't warrant coverage. I think two of the things that we just talked about are particularly significant now. One is how the vaccination campaign is going. And we each talked about some of the questions that can be woven into that in terms of priority groups and equity, and getting the most people vaccinated versus focused on getting the right people vaccinated. So vaccination is one big thing. And I think these recent new strains or variants, and how well the country is doing at tracking them, whether genomic testing does grow exponentially the way that scientific leaders say is needed to have any hope of keeping them from really, really spreading a lot. And just what the government policy is to try to do that, to help people try to do that tamping down. So I'd put those at the top of my list.
I gave a long list before, but I'll just add one more thing that I think maybe some of you might find surprising coming from me as a scientist and public health person, which is that you can't just listen to scientists and public health experts. And what I mean is, I've been asked this question a lot on CNN and others recently, with people saying, hey, you have these variants spreading. Is this really the right time for us to be loosening restrictions in many places? Shouldn't we instead be having a lockdown to control these variants? And you know what, from a purely infectious diseases standpoint, if your only goal is to control the infection, sure, of course, right? Have a lockdown. That's if we lock everybody down, we're not going to see spread of this virus by definition. But is that really likely to occur? No. And pandemic fatigue is very real. People's livelihoods are very real. And there's just no way that when we see infections trending down, hospitalizations trending down, that we could actually be using the political capital now to convince people to lock down. And so how this relates to the Biden team is they're in a very difficult situation. Having said during the campaign, all along, they're going to be listening to scientists. And yes, they have been putting scientists front and center. I think that they're doing a really good job of following the science, but you cannot just listen to science and public health when it comes to formulating policy. Should it guide your policies? Absolutely, but there will be other people that have to weigh in. There'll be decisions made often that go against the guidance of public health. And I would be very curious to see how they end up balancing those disparate measures.
If I could just jump in, I think there was something very fundamental to what you said about the trade-offs between locking down for maximal protection versus keeping some eye on not killing off the economy, which is that a lot of these issues have big trade-offs to them. And I think if we can elucidate what some of those trade-offs are and show how policymakers or public health officials or state government leaders or local mayors are weighing those trade-offs, that will really help the public understand what's going on here.
And also, to add to just how complex it is. I think so often public health officials and mayors have been at this, they've been put into this position where everybody is angry with them because nobody's happy with the outcome. They're on the front lines of all that anger from every side. But I think to illustrate how complex these decisions are is really important.
Thank you. And I think this is really going to be, and has been, a very big local and state story as well. And we've seen those kind of flip-flops, certainly here in California, and just trying to tease those apart, I think could yield many stories. I want to turn to another topic, which is that going back to your point, Lena, about talking about health equity. The Washington Post reported recently that only 20 states were doing any tracking of race and ethnicity data on their vaccine dashboards, even though it's required by the federal government. And 20 actually paints a rosier picture because only 3 of those states have provided relatively complete data, while another 17 have major gaps, the Post found, with unknown being the first or second most frequent category in almost every state. So why does this incomplete data matter for the pandemic, and what stories might local journalists pursue?
I guess I can start, and then Amy, I'm sure has a lot to add about this too. I mean, without data, we don't know what's going on. Without data, we're flying blind. And so I think that the reason why this has not been collected is that if something is not required, it probably is not going to happen. And it's not because of malfeasance or some malintention. It's just that people are really busy. The same public health officials that have been standing up, testing, contact tracing, are now doing vaccinations. And I mean, be assured, by the way, that this information is being collected. Somebody has this information. And so I think all of you can help in uncovering it. But I think in emphasizing, once you see those data, the next step is going to be, well, how will you address these disparities that we're seeing? And I think race is certainly a portion of information to be collected. So is income level, and so is geography and zip code, because I think that type of granular information is going to be really important. It may be that a certain area doesn't have access. And by the way, I think that when it comes to communities of color, vaccine hesitancy is used as an excuse. Yes, it's very real. And yes, it is something that we have to address. But I think so often it's easy to say, well, they don't want it. And so that's why people from other areas are coming in to get the vaccine. Well, we should also be looking at, is access the main reason why they're unable to get it?
So first of all, I want to credit a couple of my talented colleagues for those findings that you were citing, Michelle. That was not my work. I agree with you, Lena, that in many instances, those data are somewhere. But I think there's also an issue that's worth looking at a community or state level, which is that when people fill out registration forms to get a vaccine, they're asked that question about demography. And there's a lot of blanks being left. So I think one thing that reporters can look at is just what is happening where they are. How much of this data is being filled out by consumers signing up to get a shot? How much of it is, bad record keeping technology at the local level or at the state level that's preventing those 2 layers of government for reporting as they're required to do to the Center for Disease Control and Prevention, which basically says you have to tell us who's getting shots. I think at a federal level, there's really no enforcement mechanism that I'm aware of for that kind of reporting to be ensured. So I think those are all journalistic questions that we can bring to bear, no matter what tier of government or what kind of community we're sitting in or looking at.
So I have some more questions here, but we are getting a lot from our audience, so I'm going to turn to them, and we'll try to get through as many as we can. And I don't know if we can get through all of them, but if not, we'll see if we can come back to some of those with the blog post or some other way to try to get to some of them. But I'll start with one from Alicia Berkmeyer, who says there's a lot of noise across the industry on who is getting the vaccine for distribution. Most of it is being delivered out by hospitals and pharmacists. At what point do you think primary care providers will be able to be included in this distribution plan?
Lena, do you want to go first?
Yeah, sure. And actually, just one more thing, if I may, to Amy's last point about the data. Again, this is where I think, I don't know that this is where the Biden administration is going to go, but they can go in this direction. They can be a lot more heavy-handed, as in they could say, those locations that do not provide demographic data, we are not going to give you vaccines anymore. You are not a vaccine administration site for us unless these data are collected. And I think, again, I don't know that they're willing to go in that direction, but I think it's really important. I think both the carrot and the stick is important. There are a lot of places, including that the questioner is asking about primary care doctors' offices. A lot of doctors' offices want to have the vaccine to be able to give to their vulnerable patients and to their patient panels. Pharmacies, I don't know any pharmacy that doesn't want the vaccine. It's not just big pharmacy chains, it's local pharmacies that want this too. They have people who are interested, they know how to do this, they have patients that are coming to them, calling them day and night, asking for them. It's just a question of, I think, getting into those who are most able to distribute it. As to when this is going to happen, I think a lot of that depends on supply. So I don't know. I think it's a first step that they're giving it to 6,500 pharmacies. I think that doctors' offices are probably going to wait, and probably, I would guess, going to wait until Johnson & Johnson, if it's approved, because that vaccine is able to sit in refrigerator temperatures for months, which is going to be important for smaller doctors' offices.
So I'm going to say these things in the form of statements, but they're really questions that any reporter can be probing where they happen to be. This is a fairly new effort. It just began in December, not very long ago, for the federal government to allocate vaccines based on population, and then for it to be up to those states to decide how they're going to further distribute those vaccines. And states have not all been making the right call. Sometimes they've given a lot to hospitals, and the hospitals found that they didn't have enough people willing to take those vaccines. So they were trying to figure out what to do with the excess vaccines. In some cases, it sat in freezers. In other cases, it was given out to people who weren't necessarily in the top priority groups. So I think this is kind of a work in progress. This whole question of, once a state gets a batch of vaccine, what it does with it. And I think that as reporters, we can be watching that pretty closely to see what we think is working and not working. As for doctors' offices, I agree with you, Lena, that if you're a big HMO, you've got capacity to store vaccine. If you're a solo practitioner, family practice doctor, or an internist with a very small staff, the Pfizer vaccine, for instance, as some of you probably know, requires storage at exceedingly low temperatures. So the capacity of individual doctors' offices to be involved varies a lot. And from the vantage point of the public health department, this is something we actually, shockingly, Lena, haven't mentioned yet. Public health departments have been sort of under-supported in this country for quite a long time. So it's not as if they're rich with staff, or in some cases, technical expertise to be figuring out how to give out this vaccine, how to work with doctors' offices. That takes people power to make those decisions and make those policies. And, I think this is all stuff that can be looked at anywhere in the country. To what extent is either the state health department or a local health department able to do those things that optimally might be done to make it easier to sign up to get a shot?
We have a question from Johanna Ryan, who says, opening schools is a Biden priority. Most parents agree, but many lack confidence in their local school district to do it safely. What resources do schools really need to open safely? Extra people, extra space, testing? How much money will that take, and how can communities make sure they get what they need?
I can start unless Amy, would you
Yeah,
like to?
have at it.
Sorry?
I said, have at it.
Okay. So here is what I would love to see from the CDC. And by the way, I also have a very specific point of view here, having ran school health in Baltimore, and I've also written a number of pieces actually that take a different stance than many other public health experts who are much more on the side of reopening. Of course, I think that students should be in school if at all possible, but I think that we are leaving out one of the problems, which is even if schools are not contributing substantially to community transmission, that does not mean that it doesn't pose individual risk to the teachers and staff who happen to be in that school. So all that said, I think that the CDC can do, this is what I would like to see. I think the CDC can put out, let's say, for 3 levels of community transmission. Here are the 10 things that need to be done if your community transmission level is at a pretty low rate. Maybe your school only needs the following 10 things, masking, separated by 6 feet, etc. Then at a middle level of transmission, you need those 10 things, plus you need 10 additional things. And then maybe at this very high level of transmission, you need the following 10 plus 10 plus additional 20 things. I think they need to be very explicit, because it's only with that kind of explicit guidance that local schools and parents and teachers can really weigh their own risks based on science, but also based on knowing that there is a list of federal criteria so that states and parents and teachers are not left floundering on their own.
Well, I would say that this whole area is a really ripe opportunity for people who do what we do for a living to write accountability stories about what the Biden administration says it's going to be doing. In early December, just weeks after it was clear that he was the president-elect, now President Biden laid out 3 goals for his first 100 days in office. One of them was, he phrased it as this, to enable most schools to open by the end of his first 100 days in office. So that, whenever a public official holds out a quantitative goal like that, like my little brain goes ding, 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 there's a story to do. Is he pulling it off? So I think that you can look at that in your own communities and figure out, are there ways to write about the extent to which that's coming to pass? Similarly, in the national strategy for COVID-19 that by this time he was just barely the president, put out his first week in office, which was really a compendium of what he'd been saying over a period of weeks. It wasn't a whole bunch of brand new ideas, but it kind of synthesized them. He said that he would like a couple things to happen to make it easier for schools to reopen. One is for FEMA, the Federal Emergency Management Agency, to have the money to purchase supplies for cleaning so that teachers and families feel more comfortable that school environment is going to be safe. He also said that he wants to have more testing available for schools so that if there's an outbreak, it can be identified really fast and schools can do the right thing. Those are very good policy announcements. What's the follow-up going to be? That's our question.
Thank you. And we have a question. How will the vaccine be distributed to the homebound? I've asked all local officials and they have no answers.
So I should say that is a great question to which I do not know the answer, and I haven't seen reporting. And whoever is asking that question, you just keep asking and asking and asking until, well, let me say that rather than finishing the sentence the way I was going to finish it, I am in journalism in general a big believer in what I think of as negative space, kind of like if you think of art, negative space. I think it's really useful to write stories or include in stories what is not being said and what is not known. So if you who are trying to find out about the homebound are discovering that there is no plan for the homebound, the absence of a plan is a story rather than preventing you from writing that story. So keep going.
Lena, did you want to weigh in on that one or?
I also do not know the answer to this, so agree with Amy.
Okay. We have a question from Hugo Morales who says, is any state or county doing a good job on vaccination or testing? And I know I've seen data, for example, and stories about, for example, West Virginia being one of the best states, but where can reporters go to get that kind of data on both those questions?
Well, at risk of touting my own newspaper too much, the Post has an online tracker of both cases and deaths is one tracker, but more recently, I've got a terrific colleague who's basically maintaining this whole sophisticated tracking operation, and there's a vaccine component. And I might be wrong about this, but I think it's broken out by state. So at least I'd take a look at that. That's the quickest thing that comes to mind, though I'm sure there are others. Do you know, Lena, whether Johns Hopkins University, which has been doing a fabulous job of tracking cases and deaths both in the United States and internationally, do you know whether they've started doing vaccine tracking or not?
I don't know, but I will say this, that I get my information about who's doing well on testing, contact tracing, et cetera, from looking at local newspapers, from local reporting, because I just don't see these as national stories. I mean, I try to do my part to lift up. Michelle mentioned West Virginia as a good example, to try to understand what is it about places like that are doing well. There are some places like Maine that have done incredibly with contact tracing. Why is that? And so, but I get all my sources not from academic literature and from academic databases, but actually from all of your reporting.
The other thing I just want to mention is that a number of news outlets that are putting out really authoritative data, and two that come to mind right now, but I know there are others, are the New York Times and LA Times, and it could be that the Post is doing this too, are putting the data and their analysis on GitHub. And that can then allow reporters from anywhere to download it and to localize it and to use it. So another thing to look for is a kind of public service effort that outlets and other sources, of course, these kind of dashboards are doing to make it easier for you to assess that. And because this is such an important question, we'll try to also answer this separately in a blog post that touches on where you can go for some of these different data sources. We have a question, an accountability question from Susan Jaffe, who says, if vaccines are wasted or spoiled, where do providers report that, and are there any consequences? Also, is there any system for using leftover doses other than haphazardly vaccinating anyone who happens to walk by and wants it?
Well, first of all, I know Susan, so hi, it's nice to see you through the ether here. So this goes to the point that and Lena, you made this point as well, that there hasn't been a lot of penalty systems for people who aren't doing the right thing, whether not doing the right thing is related to reporting demographic data on vaccinations or to using vaccine right. Lena, you made the pretty strong suggestion that places that aren't using their vaccine in an efficacious way maybe shouldn't be getting the next batch so readily. I mean, that's a debatable point, but that's one way of thinking about it. So Susan, to your question, this is not something I have firsthand been writing about, but I've got colleagues who are writing about it. And to use the technical term, I think this is an absolute mess. There have been only a few instances. I mean, there was one case in, I think it was Wisconsin, in which a worker deliberately spoiled vaccine and is now being prosecuted for it. But we don't know of instances in which, other than by anecdote, in which vaccines been giving out kind of helter-skelter because there's some left at the end of the day. I mean, we had a story here in DC covered by a couple of my local reporting colleagues about, a couple that just happened to be in the right place at the right time at a grocery store at the end of the day. And the pharmacist kind of said, you want to come over here, I've got some left over. We don't really know how common that is. And that's again, really ripe for local reporting. Just talking to local pharmacies. I mean, it's just straight old shoe leather reporting. One thing that is being talked about by both the Biden administration and manufacturers is thinking about how to get the maximum doses of vaccine out of every given vial. So there's a push on now to that the Biden administration has been talking about to purchase more, I think, are they syringes, I think, that will extract the very last bit of vaccine that might otherwise be left in the reservoir in the vial. That's something else to look at. Is that being done where you are? And is that giving pharmacists a sense that the whole vaccination thing is being done to the maximum amount, given the scarcity of the resource of vaccine doses?
So I know that our time is up, and Amy said she could stay for another little bit. Lena, I don't know if you have a hard stop or if you can stay for maybe one more question. But if you have to sign off, we understand. But I wanted to, for a final question, turn to a really touchy topic. We have somebody asking a question that really gets at some of these vaccine hesitancy questions in different communities, asking about whether the talk about South African and Brazilian strands being more deadly and more contagious, is this a dog whistle for Black people somehow not being able to have this, or somehow that tied in with who got tested on these things? And just a lot of, this question has a lot of kind of concerns about whether there's some connection between that conversation about the variants and how, or if Black communities will be, getting their fair share of the vaccine.
Well, I mean, let me start perhaps. We have nomenclature for illnesses, for viruses, for a reason, right? That there's a reason why we call coronavirus SARS-CoV-2, COVID-19, instead of calling it the China virus and other things. I think the variants have emerged in such a way, and unfortunately the nomenclature is such a mouthful that it's difficult for, especially since they're new, for us to say, this is the B1117 variant, this is the B1351, this is P1. I mean, it's harder. And so I think people have resorted to using the shorthand of UK, South African, Brazilian. I will tell you that my husband is South African. His entire family is in Johannesburg, and there is a lot of talk within the South African community about why is this, is there a concern about stigmatizing a country and its people, potentially hurting? I mean, they weren't really thinking in this, I think, the way that the questioner was thinking, but in hurting tourism. I mean, in hurting people who are from those countries in some ways. And so I do think that turning to the nomenclature that better reflects the science and stays away from the place of origin is important, especially because we have potentially many homegrown variants right here that we don't even know about, just because we don't have the genomic surveillance. And so some people have said, well, why are you punishing countries that have been doing good surveillance? I'm not sure how this ties to the issue of vaccination, only to say that, again, I think it's, in a way, I just am concerned by some of the conversations I've been hearing around vaccinations as tied to, or lack of vaccinations within certain communities tied to hesitancy, rather looking deeper at what are the things that we can do as a society in order to overcome these problems.
Let me make a couple of final points. And I want to start by saying that, everything that I've been saying, you should hear me saying not as a subject matter expert, but as a working journalist. So these are all questions that I'm asking along with you, day in and day out, and week in and week out, and weekends too, I guess. It's been kind of a lot of work. But I want to go back to Lena's point, which is that some of these sensitive racial and ethnic questions and socioeconomic disparities aren't things that arise from this once in a century pandemic, but are revealed by it. And I think that that point is woven into the question that Michelle, you were articulating on behalf of one of our audience members. I also think, and this has been one of my themes, which is how to hold the Biden administration to account for what they have been saying. They've been talking in their early days about understanding, or they say they understand, that they cannot alone preach everybody should get a vaccine and expect if everybody believe it. Anthony Fauci, who is now the new president's chief medical advisor for COVID, in addition to his role at National Institute of Health, he talks an awful lot about vaccination, and he does a lot of speaking to specific communities. That said, the new administration has been saying over and over, they understand that they need to start talking to the community groups that have real credibility with different parts of the US population, and trying to enlist them as credible messengers. I mean, there's a fair amount of research data that if you're trying to persuade somebody to do something that they're not sure they want to do, the presence of a credible messenger matters an awful lot. You know, I think we're going to need to watch over time whether this kind of value system that the new administration is articulating about working with communities and working with leadership groups in communities that can get messages across translates into reality. And that's something that we're only going to know by covering them closely over a period of time, wherever we're working.
Well, I want to thank you both for this really tremendous discussion and all your great ideas. I also want to thank our audience for their great questions. I'm sorry that we didn't have time to get to all of them, but we have a regular column called You Asked, We Answered, where we try to get at some of these questions that we don't have time to get to in our webinar, and we will definitely try and do that with some of these. I also wanted to just offer up one idea that was sparked by the conversation from one of our questioners about accountability, and also Lena's remark about how do we keep track of and report on the good players who are really doing a good job. And that is that you can use some of the engagement tools that news outlets are deploying more often, and do call outs and set up mechanisms where you can turn to your community and ask them to share with you what they're seeing out in the field, and involve them in being eyes and ears for you. You have to then, of course, fact check what you hear, but it's a way to get information that you might not be able to do, especially if your newsroom is a little bit thinly staffed, and get some leads and where to go for here. So it's just a little tip. And with that, I want to thank you all. We will be posting this webinar a little later today on centerforhealthjournalism.org. We're about to send you a survey, and we ask you to fill it out, telling us your perspectives on our speakers, as well as webinars you'd like to see next. And should you want to support our work and this webinar series, please just send a text to 41444 and type CHJ for further instructions, and we will take you from there. Thank you so much. Good luck with the reporting. Good luck with your work, and have a good day.